Let's go ahead and get started. Thank you everyone for joining this October AIDS Clinical Conference. I'm delighted to introduce our speaker and so very grateful that she's able to join us today to speak on this very important topic of depression in people with HIV. Dr. Cournos is a professor of clinical psychiatry at Columbia University, and she has a long-standing career in HIV and mental illness, which began in 1983. She has worked both locally and globally, not only providing clinical care, but also educating, doing research in this space, advising on policy and developing guidelines. She has published many articles in this area, over 170 articles and book chapters in this area. She has worked as a director of the Washington Heights Community Service, a program in New York, where she's mainly located. And again, a long-standing career in this space, and we're very fortunate to have her speak today on this very important topic. Thank you so much, Dr. Cournos.
Thank you so much for inviting me. I'm going to start out just by showing you this disclosure, which says that this presentation is in part funded by HRSA, but doesn't represent HRSA's perspectives, they're my own. And also to let you know, although it's not on the slide, that I don't have any conflicts of interest. And I'm trying to keep this talk very practical and very much geared toward people who are working in HIV care settings rather than psychiatric settings. So my objectives are to help people learn approaches to distinguishing between distress, major depression, and bipolar depression, to understand which treatments for depression can be most realistically implemented in HIV or primary care, and to be able to cite some of the common psychiatric conditions that are comorbid with depression and how they can affect treatment. I'll also try to talk slightly slower. I'm a New Yorker and we talk so fast here. So globally, depression is referred to as a common mental disorder. And the reason why it is, along with anxiety disorders, is because these are really very common disorders. And there have been worldwide studies suggesting that the rates of these common mental illnesses are higher in the US population than in many other countries. And I can't really say why that's true, or even if that's true, and we're just measuring things differently. But we have, a long history of having a lot of mental illness. And we learned during COVID that common mental disorders affect not only patients, but their healthcare workers. There was recently an article talking about how the stigma of depression has lessened than it used to be, but it still is a major barrier to diagnosing and treating depressive disorders. And that's true for both patients and providers caring for them. So the mental illness has gotten a lot of attention during the COVID-19 pandemic, mental illness, and I have to say also mental wellness, because the rates of depression increased during the COVID-19 pandemic, and healthcare workers were among the most severely impacted groups. And that was very interesting because all of a sudden there were more studies about healthcare workers than there was about their patients, showing just how negatively COVID-19 was affecting them. The other interesting thing that happened during COVID-19 is that we became more and more aware of the social determinants of health and mental health in the US. Various political events were also going on at the same time, but regardless of the political events, increasingly we have been thinking about racial discrimination, income inequality, and all of the social determinants of mental health. There's a lot of discussion about our country being in a mental health crisis. When you do surveys of people in general, the public thinks that the US is having a mental health crisis. And while I'm going to focus on people living with HIV, one of the things that COVID-19 taught us is that we're all in this together, patients and healthcare workers. During COVID-19, our HIV patients suffered, and healthcare providers who sometimes have HIV but often don't, also suffered. We all suffered together. There have been many, many studies about rates of depression in people with HIV. I would say that in the US, people estimated at about 30 to 50% of HIV positive people in care have depression. And the rates, if you look at worldwide studies, have really varied by the design of the study, how it was measured, where it was done. And finally, I just want to mention that in the US in particular, we see a lot of comorbidity between depressive disorders and other psychiatric illnesses, including alcohol and substance use, anxiety disorders, and PTSD. So I also do want to mention that even though I won't be talking about anxiety disorders, that the treatments for depression and anxiety are really very similar, both in the therapies that can help it and also the medications. And that antidepressants are also anti-anxiety drugs. So that's useful to know. So the last time the WHO did a thorough assessment of what the major causes of disability are in the world, so now I'm talking about the whole world, of the 20 most common causes of years of life lived with disability, mental illness accounted for 7 of them, with depression ranking the highest. So in 2012, it was estimated that major depression was the #2 cause of disability in the world. That is to say, years of life lost to disability, people who are alive but can't function because of mental illnesses interfering. And you can see all the other drug use disorders. I mean, all the drug disorder, all the psychiatric disorders, including drug use disorders. And I also want to say that even though schizophrenia and bipolar disorder are the most severe mental illnesses, they're just much less frequent than depression, which is why depression shows up as such a major cause of disability. I'll also discuss the fact that dysthymia existed in 2012, but was eliminated from the Diagnostic and Statistic Manual, which we use in the US in 2013, and I'll cover that. The WHO considers major depression as more disabling than almost any medical illness, including AIDS, and similar to having quadriplegia. So that says a lot. They also made back pain the #1 cause of disability, and I just want to say there's probably a relationship between depression and back pain. And major depression is associated with increased morbidity and mortality from common comorbid medical conditions, as well as from suicide and accidental deaths. So all these causes of death are elevated in people with depression. I'm going to talk about the 2 main types of disorders where you see depression. One is in depressive disorders and the other is in bipolar disorders. So in 2013, the DSM-5 decided not to lump depressive disorders with bipolar disorders and call them jointly affective disorders. That's what we used to do. The reason why the distinction was made was in part because they really have a different course and they require different treatments, and it's confusing to lump bipolar disorders together with depressive disorders. So major depression is the major depressive disorder that people have. And then there's something called persistent depressive disorder. And that's where what we used to call dysthymia resides, in that persistent depressive disorder category. A typical single episode of major depression lasts 6 to 8 weeks. So it lasts 6 to 8 months. That's a typical, single episode of major depression. But persistent depressive disorder is much more persistent than that. Bipolar disorders include bipolar 1, in which you see mania, full mania, bipolar 2, in which you see a less severe version of mania that we refer to as hypomania, and cyclothymia, where people cycle from high to low moods, but they never meet the full criteria for bipolar 1 or bipolar 2. And depression in people with HIV is associated with increased morbidity and mortality. And this is not simply mediated by adherence to medication, because this was shown before we had effective antiretroviral medication. that having depression by itself leads to HIV progressing more rapidly. Depression is associated with adherence problems along the HIV care continuum at every step, increased HIV risk behavior, and poorer quality of life. Now, major depression, in my opinion, is as much of a physical illness as it is a mental illness, but it's a little more complex to see in people with HIV because they also have physical illness. But if you look at people without physical illnesses, so if we leave HIV for a moment, major depression is defined by both affective symptoms, emotional symptoms like depressed mood, loss of interest, guilt and worthlessness, suicidal ideation. But somatic symptoms are a very important piece of depression, including appetite changes, weight loss, difficulty sleeping, being motorically agitated or not moving enough, fatigue and loss of concentration. And there is a lot of literature that is starting to look at whether, in fact, there's a bidirectional relationship between depression and inflammation, because inflammatory illnesses like HIV and TB travel with very high rates of depression. And this is the frontier. The brain is really the frontier of all of medicine because we understand so little about it. But this relationship between depression and inflammation is gradually emerging as something that's important. So one of the things I always like to talk about, and I'm always shocked by, is that in the US and in Western cultures, mental illnesses are often separated from physical illnesses, which is a very unfortunate way of looking at them because the brain and the body are one. And that's one of the major emphases. It's a major emphasis that I like to give, because the brain controls life's essential involuntary bodily functions, such as the rate at which you breathe and your heart rate. And the brain tells the body what voluntary physical actions it has to take to survive, such as you're hungry, eat, you're in danger, running away. And then the body gives its feedback. Well, now you're full, you can stop eating, or you're too tired to run anymore. And what's really interesting is that even though our medical system is set up to create a separation, we have many expressions in the English language that are recognitions of the fact that the brain and the body are acting in unison. So if you think about common expressions like I have a knot in my stomach, a lump in my throat, chills ran down my spine, all of these capture the physical manifestations of our emotions. So I did some work in sub-Saharan Africa where there are very few behavioral health providers. And one of the things I began to try to understand is how do you distinguish between mental distress and mental disorders? Because when you have limited behavioral health providers, you might want to think differently about distress versus disorder. So, you know, even in medicine, there are a lot of illnesses where the line is kind of arbitrary. What's the line between being a diabetic and not being a diabetic, or between having a normal blood pressure and a high blood pressure? It's arbitrary, and it's usually based on research, and we keep resetting those boundaries based on what we learn happens to people who have certain blood sugars or certain, blood pressures. And this is true for mental distress and mental disorders. There's an arbitrary line that we use to decide when someone has crossed over from distress to disorder. Mental distress is extremely common. It can occur in response to any adversity, but usually just distress alone is not going to meet the criteria for a psychiatric diagnosis. And therefore, it can often respond well to supportive strategies without having to turn to behavioral health providers. Mental disorders, by contrast, are more persistent in both subjective distress and functional impairment. And we use criteria that are in our diagnostic manuals. Most of the world uses the ICD, the International Classification of Diseases. The US and researchers tend to use the DSM, the Diagnostic and Statistical Manual. It's interesting to note that the numbers in the DSM match up to the code numbers in the ICD. So that's one place where those two manuals intersect. It's among people who cross over that threshold into disorders where it's most important to think about evidence-informed mental health interventions such as medication and psychotherapy. Again, while I was working in Africa, it really helped me to think about the WHO pyramid of mental health services. And I brought that experience there back to the US, where I found it very helpful, especially during COVID. So this is actually an old slide, but people in the US don't use it a lot. But I have found it very informative. So the World Health Organization created this pyramid of mental health services. This goes back to it's at least 10 years old. And what it showed is that there are many levels at which we respond to mental disorders. And when somebody has minimal or mild symptoms of depression, let's say, and they don't cross the threshold into a disorder, we may need to rely primarily on self-care and community care and primary care, because as the pyramid shows, the bottom of the pyramid, where the most care is available, is self-care and informal care and primary care. And when you get to behavioral health disorders, that's where there are fewer services. And so you want to think about who actually makes it to that top of the pyramid. The other thing is that anybody with a chronic illness, whether it's a mental illness or any other illness, needs to engage in self-care. So for example, if I start a patient on an antidepressant, I don't say this is going to make you better. I say this is going to help you be better, feel better, but it's going to require a lot of other things for you to pay attention to. Lifestyle factors, how you're sleeping, whether you exercise. The reality is that medications are not magic in psychiatry. We wish they were. We wish they were better targeted. So again, this just shows the WHO pyramid in its larger form. And you can see there that for people in distress, if we can get away with self-care and informal community care, we like to be able to do that. And primary care is the primary entry into behavioral health care. A lot of referrals to that level of care come from primary care. So many of you are familiar. This comes from David Spock, who's part of Washington State, right up with the National HIV curriculum. And it's free and online, and it's very interesting to screen for mental disorders. And I'm going to just review that a little bit because I'm going to talk about screening for depression. So the latest version of the National HIV curriculum has a series of tools that you can get to on automatic calculators, and I've listed what they are here. And you can see that's true for anxiety, dementia, depression, PTSD, and various substance use disorders. So if you are using the National HIV curriculum, you can be sitting with a patient, asking them questions, putting in the answers, and then getting a summary score with some advice about what to do. I'm not going to go into all of these different instruments because this is a talk focused on depression, but it's worth knowing that they're there. And not only is that true, but there's a chapter, two chapters that you don't get to in this automatic way, one on mental disorders, one on substance use, that give you other instruments that aren't connected to automatic calculators. And for those of you who like obsessional thinking, they go into the sensitivity and specificity of these instruments, which is helpful to know in terms of understanding just what does screening for mental disorders do for you. By far, the PHQ-2 and PHQ-9 are the most common screening tools. And the reason why is because they're very easy to use and they have good statistics. So they're readily available online. You can go onto the internet and find these instruments translated into at least 80 languages. They're not necessarily validated in every language. They're very well studied in the general population. You can give it to the patient to self-administer. It can be used to screen and to make a probable but not a definite diagnosis. And it can also be used to follow the patient's progress. So you see what the PHQ-9 score is on one visit, and then if it drops on the next visit, you know the patient is doing better. You'll see, if you also like to read research studies, that these are not the instruments researchers use for depression. Researchers use instruments with greater diagnostic precision when they establish diagnoses, but those instruments are very lengthy. A good instrument to really establish psychiatric diagnosis would take, 45 minutes to administer. And it just doesn't work to do that in primary care. So we know these are screens that don't give us definite diagnoses. Also in the national curriculum, you'll see a lot of information about the people who use the PHQ-2, and then if it's positive, use the PHQ-9, or the people who just go to the PHQ-9. And either way, it works. And the PHQ-2 really has two different ways in which it's used. Usually it's scored by number. So if you have a score of 3 or more, that's a sign that major depression is likely. And the recommendation is to go on to screen with the PHQ-9. But you can also do it very simply as yes, no. So the patient could say, yes, I have little interest in pleasure in doing things, or I feel down, depressed, or hopeless. And either yes leads you to do the PHQ-9. And one of the things I want to point out that I've learned, because I did 2 years of internal medicine training before I switched to psychiatry, and I've spent a lot of time going to infectious disease meetings and so on, that the symptom of little interest or pleasure in doing things is very indicative of depression. People can be quite physically ill and still get pleasure. If a family member comes to visit, a grandchild shows up. Depression is really characterized by little interest or pleasure in doing things. However, there are people who mostly have somatic complaints about depression, and it varies by culture. This is the PHQ-9. The symptoms are rated from 0 to 3. It's very easy to find the scoring for this instrument. And you'll see here's where you get into some of the somatic symptoms of depression. I also want to mention that one of the questions that makes people very anxious, I've done a lot of training of clinicians in HIV care settings to screen using the PHQ-9. And when people aren't used to doing that, they're very nervous by that question number 9. Would you have thoughts that you would be better off dead or of hurting yourself in some way? Because if a patient says yes, you think, well, what do I do now? But there's also an anxiety that if you ask people about suicide, you put ideas in their head. That's definitely not true. Most people who are severely depressed think about suicide, even though it's only a subgroup who are truly at risk for committing suicide. So you can ask that question safely. It's very important to understand that depression is like a final common pathway of the brain that could be due to many different things. So one of the things that's often overlooked is the number of medical conditions that either cause or contribute to depression. And, they're the common ones we know about that aren't specific to HIV, like hypothyroidism is a common one, alcohol and other substances, prescribed medication, common, hypogonadism, which we see in HIV associated with low mood. And the other thing to remember is that depression is also associated with significant cognitive impairment. And you can be fooled because in HIV, we have a lot of cognitive impairment into thinking that someone's cognitive impairment is due solely to some neurological problem, when in fact it's being exacerbated by, and in some cases, even caused by the depression. And you see this best when you're treating young people without any medical diseases. And you can see how confused even young people who have no medical illness can get with depression. And you also want to try to rule out bipolar disorder, and I'm going to go into why that's the case. So these are the scores on the PHQ-9, and you'll see there's minimal, mild, moderate, moderately severe, and severe depression. And the higher you are on this scale, the more likely you actually are to have a depressive disorder. But as I was saying, we really don't have enough behavioral health providers to refer everybody with mild or minimal symptoms to specialized care. So we've really relied on, in international settings, and I think since COVID in this country, on self-care and informal supports at lower levels of care to improve symptoms and also to try to prevent more severe symptoms. And we also now are more aware of the social determinants of health, what lack of food and lack of shelter and no money and all the things that contribute. So I think we're moving closer to understanding that many things contribute to depressive symptoms, and some of them can be addressed by addressing people's socio-cultural, economic, racial, whatever circumstances, all the social determinants of health can really make a difference in trying to prevent full-blown depression. So after COVID, we were bombarded with advice about how to stay well, since all of us were experiencing varying versions of being told we should stay home, we shouldn't socialize anymore, or going to work and being very frightened about what could happen at work and whether we would get infected. And I think everybody knows these things, and I'm not going to go over it, but there's a host of easy to find activities that are intended and have been shown to really help people improve mood. And they're very important to use. And that's why when I work with a patient who's depressed enough to have a diagnosis of depression and is also getting an antidepressant, I tell them antidepressants alone aren't going to keep you well. You really need a routine that keeps you healthy. And that is your own self-care routine. And it's become increasingly clearer that the course of chronic illness is deeply affected by self-care. The best studied psychotherapies for depression are cognitive behavioral psychotherapies and interpersonal psychotherapies. And there are a lot of patients who would prefer to have therapy. Usually these therapies are used for mild to moderate depression, and sometimes even for severe depression, but often in combination with antidepressant treatment. What happens when depression becomes very severe is that people may lack the concentration or the ability to engage in a psychotherapy. So sometimes in the most severely ill depressed patients, we really need to use somatic treatments. In settings that have low behavioral health resource providers, like in Africa, it's also easier to use antidepressants than it is to give therapy because it's actually less time consuming. Sadly, psychotropic medication leaves, we're far away from having great psychotropic medication. We have no penicillin for depression. So there's no equivalent of testing patients for sensitivity and specificity to different antidepressants. There are no biological tests to guide us. We can do, cytochrome P450 enzyme studies and see who metabolizes drugs slower or more quickly. That might help us with dosing, but it doesn't tell us who's going to get better in terms of the therapeutic response. So the reality is that we treat all patients by trial and error, monitoring tolerability of side effects and degree of improvement. And those are the two big issues. Does a patient tolerate a medicine? And does a patient get better on the medicine? We define in psychiatry response as an improvement of more than 50% in the patient's symptoms. And that's much less desirable than remission, where patients have few or no symptoms. And one of the reasons why response is less desirable than remission is that when people persist in having symptoms, even if they've had a response of a reduction in symptoms, they stay at risk for full-blown major depression. So we like remission if we can get there. The study that I have most relied on to try to understand antidepressants and to try to teach about them is a study called the STAR-D study. It's the largest and most inclusive clinical trial that was ever conducted on the treatment of non-psychotic unipolar major depression. It was a multi-site, multi-step, prospective, randomized, federally funded clinical trial that enrolled about 4,000 patients, so it had no pharmaceutical money in it. And many people who were enrolled if they had medical and psychiatric comorbidities, because there was an attempt to try to understand what happens in the real world. So, you know, there are a lot of research studies that want pure cases of depression and will take people with comorbidities, but that doesn't tell us how the real world works, because in the real world, comorbidities are very common. And this trial had 4 sequence treatment steps in its algorithm. And the first step for everyone was treatment with the SSRI antidepressant citalopram, also called Celexa. And there were 2 endpoints, as I mentioned, response and remission. And then if citalopram wasn't successful in step 1, there were 7 options that the patient and provider could decide together what the next step was going to be. So you could switch to another antidepressant, you could add on cognitive behavioral therapy, you could be on 2 antidepressants or just 1, but so that's a different antidepressant. And then there were also steps 3 and 4, which, you know, went on to more and more uncommon treatments that people use in terms of psychopharmacology. And that study began in 2003, and there are literally hundreds of papers on this. But most people who really like to understand psychopharmacology consider this study one of our best guides. This is a complete oversimplification of the study, but what I wanted to show you is that step 1 is citalopram. So everybody, of these 4,000 patients, everybody started out with that. 37% of the patients experienced acute remissions. That is to say that they really had very few symptoms. They got mostly completely better. 49% of people only achieved a response, which was greater than 50% reduction of symptoms. But if you put those 2 things together, you can see you got improvement in a majority of patients. This is acutely. It doesn't tell you anything, this slide I'm showing you now, about whether people decide to discontinue their medication or whether they relapsed on a medication or whether they just decided to drop out of a study altogether. So this is the most optimistic view of what our medications do. Now, if you ask providers, including me, do I think that only 1/3 of my patients get better on an antidepressant? That's not my impression, but this is an RCT, a randomized controlled trial. And, you know, maybe we as clinicians delude ourselves a little bit. I don't know. But what I've concluded is that if people are going to prescribe antidepressants in primary care, it's good to know that 2 trials is what you want to think about. Why 2 trials? Let me go back to the previous slide. Because in step 2, you still get an improvement of about 1/3 of people going into remission. But by the time you get to steps 3 and 4, the rates of remission are very low. And that's true for response. In response, step 2, you get about 1/3, but step 3 and 4 are low. And therefore, if you've given someone a good trial of 2 different antidepressants, you want to think that you're probably going to need to refer this person to a behavioral health program because they're not likely to respond to your next trial. And other reasons to refer to specialty care usually are bipolar disorder, psychotic depression, Risk for suicide or violence and diagnostic uncertainty are common reasons to refer. It's very important to know that there are many specialized treatments out there that we don't routinely use, and they aren't used in primary care, but they're very important to know about, because when someone has refractory depression, they are really robbed of a real life. People with severe refractory depression are not really participants in this world. And whether they're taking their HIV medication or not, it's very important to try to get people well. And we have various brain stimulation treatments, which started out as ECT, but now we have other ones as well, which I've listed there. We're experimenting with ketamine, which when I was in training was just considered a drug of abuse. But you can't just go out and take ketamine and expect to get better from depression. These are substances that are used in very controlled environments and are accompanied by people taking patients on a journey. There are experiments with other psychedelic medications. So none of these are things you're going to be doing in primary care, but it is good to know that when someone doesn't get better, we do have more, we do have other and more invasive treatments that we do like to use to get somebody in remission from depression. I'm going to spend a little time on bipolar disorder. It's marked by extreme highs and lows, and intense changes in mood, and can last for hours, days, weeks, or months. It was classified separate from depression because it's actually a much more difficult disorder to have and to manage. It's important to know that patients seek help usually in the depressive phase, and frequently not when they're manic or hypomanic, which is often a time that people either deny anything is wrong or have extra energy or feel good in some way that makes them very reluctant to go into treatment. It takes on average 10 years to make a correct diagnosis of bipolar depression. And that's because most people with bipolar disorder spend most of their time depressed. So a lot of time bipolar disorder starts out looking just like depression. And it's been estimated that over 3 in 20 patients diagnosed with depressive disorder actually have unrecognized bipolar disorder. And the reason that's important is because the treatments we use, the medication treatments for bipolar depression, are mood stabilizers, like lithium, anticonvulsants, and atypical antipsychotics. Whereas for major depression, we're using antidepressants. And giving antidepressants alone to people with bipolar depression can precipitate mania. There are no brief screens for bipolar disorder. The national curriculum has a long screen with 13 items called the MDQ, but it's always worth asking if they have a close relative who was ever told they had bipolar disorder or what we used to call manic depressive illness. You can ask a few questions without asking all the questions. The one I like best is, has there ever been a period of time when you got much less sleep than usual and found you didn't really miss it? Doesn't that sound like a state you would, that has some appeal to it? You can just keep going and going. And having treated people with bipolar disorder, slowing them down is one of the things that gets that people with bipolar disorder often seriously dislike, and accounts for some of the non-compliance we see. Most people with bipolar disorder need lifetime ongoing management. People who really can stay well have learned how to maximize all of their daily rhythms and routines. But the other thing I wanted to mention is that people with bipolar disorder are often very creative. So you know that in psychiatry, we focus on pathology, not on assets and talents. But the world is filled with people in bipolar disorder who are famous writers, artists, and creators. And that includes people with HIV. And I'm going to show you one because I'm old enough to have seen Alvin Ailey dance. He was an American modern dancer. He had bipolar disorder, alcohol and drug use, and HIV infection. He died of AIDS before there was effective treatment. but his work lives on through the Alvin Ailey American Dance Theater. And I like to mention the creativity of many people with bipolar disorder, just because some of their accomplishments are remarkable, and they're not the accomplishments of people who don't have this disorder are likely to achieve. So again, it's not a question of it being all bad or good. It's a question of how can you maximize your well-being and your functioning. Our diagnoses have a high degree of comorbidity with one another because we don't understand the underlying biology. And it doesn't help that we silo everything so that you go to one place for mental illness treatment, another place for substance use care, and that a lot of people receive treatment, for one but not the other disorder. Many people receive no treatment for disorder at all. So these are problems. The way we've siloed care are problems. But it was a problem before we siloed care too, and I'm not going to go into that. There's a lot of stigma that I think drives the difficulty with mental illness and how to diagnose it. And there's a lot of fear that never is addressed in training. When you think about typical training for physicians or nurses, maybe, I don't know about social work, I don't know that as well, but in the prescribing fields, very little time is spent teaching people how to stay calm when someone's behaving bizarrely. And that leads to a lot of misdiagnosis. So just to give you two of the many studies that I could give you is that in bipolar disorders, we see a 42%, this is not related to HIV, a 42% prevalence of alcohol use disorders and high rates of cannabis and other illicit drugs. And looking at people who have both depressive disorder and a substance use disorder, people with both disorders do worse than people with either disorder alone. So these comorbidities lead to worse outcomes. In alcohol and substance use, and feel free to type your questions. I'm coming to the end here, okay. In alcohol and substance use, I'm going to only touch on that because I don't have time to touch on everything. This is one of the most problematic comorbidities in people with HIV infection. And the main thing to take away from my talk now is to remember that two disorders require two treatments. If you treat depressive disorder, it doesn't mean that alcohol and substance use disorders are going to get better. And likewise, if you treat alcohol and substance use disorders, it doesn't mean the depression is going to get better. So really, you want to think about two treatments for people who have both depression and substance use. There's a lot of people say a lot of things about antidepressants in people with HIV. Some people think they don't work as well. The reality is that we have done very, very little research on the use of psychotropic medications in HIV. And almost all of our conclusions have to be extrapolated from the general psychiatric literature. The primary reasons to treat depression are to relieve suffering and to improve quality of life, to reduce disability and increase ability to function, to reduce mortality. And we now know for some medication, for some physical illnesses, for some chronic physical illnesses, if you treat depression, you will increase lifespan. We don't know that for HIV. So again, we don't know, there's mixed evidence about whether treatment of depressive illness by itself improves rates of viral suppression. In my reading of the literature, you need an adherence intervention, not just a depression treatment. Even, in other words, depression may be associated with non-adherence. That doesn't mean treating depression isn't automatically associated with better adherence. And we still don't know whether treating depression will extend the lives of people with HIV infection. We do know depression shortens life in people with HIV. We don't know if treatment of depression prolongs it. So here are my conclusions. I wanted to save 15 minutes for questions. That depressive disorders are common among people with HIV, And even though I've just given you a long story about all of the steps and how difficult they really are, nonetheless, depression, if you persist, is a very treatable disorder. And it's really important to persevere because they rob people of a sense of really being alive. You want to rule out the medical causes of depression among people with HIV or in anybody else. You want to think about the severity of the symptoms. If you have to triage to behavioral health and you have to pick who to triage, you want to pick your more ill people. You want to, if you can, send people with bipolar disorder to be stabilized in a mental health setting because they're much harder to stabilize than people with depression. We have psychotherapies and medications, which are often effective, but as I've mentioned, self-care is extremely essential and other support helps. And patient preference is an extremely important factor in what the treatment is going to be. So we really need to match our treatments to what patients are willing to do. And by the way, that STAR-D study did allow for that. Patients would be asked, do you want to add a psychotherapy? You want to add another medicine? And patients got to say something about what they wanted. Patients always get to say something about what they want. So we want to just recognize that. That is my last slide. I'm going to stop sharing. And I've left time for you to ask questions. And I hope that you do ask questions.
Thank you so much for that wonderful talk. That was very practical as well. And I'm going to open it up to see if there's any questions from our audience members. You can feel free to enter them in the Q&A box there if you have any questions. While you're typing there or thinking about it, I just want to go back, Dr. Cournos, to before you started your talk, you talked a little bit about mental health and the concept of prevention in mental health, and I'm curious what that looks like to you.
Well, you know, so mental health really has not focused on prevention until very recently when we started to talk about wellness. So for whatever the reason is, you know, you think about prevention, right? We think about it for everything, for heart disease, diabetes. I mean, there's a lot of things you can do for prevention. It just hasn't really permeated the field until we've had so many people with so much mental health symptoms that we really have to start thinking about it. If you talk to people who have these illnesses and manage them well, to me, I think I've learned more from patients who have depression and have bipolar disorder on how to stay well, or have any mental illness, on how to stay well. What you learn is that even if you have a disorder, and many of our disorders are chronic, you know, most of our disorders in psychiatry are recurrent disorders. But if you talk to people who have depression or bipolar disorder who can manage it well, they'll tell you, they'll learn. For example, a person might learn. I'll tell you some of the things patients have told me. I've learned that I can't stay up past a certain hour. If I stay up later than X time, I'll wake up the next day and I'll be manicky and it won't work for me. Or people will tell you, I have to get my exercise. You know, if I don't get on the treadmill and I run, I start to really get, you know, depressed or anxious, you know, things like that. So there's patients know the self-management techniques that I'm talking about. And it's often interesting to ask people who are actually doing well with a mental illness, how do you manage? Because I think you'll find that whether they're getting psychotherapy or medication or both or neither, people with a chronic disease who do well with a chronic disease learn a lot of tactics for managing.
Thank you. There are a few questions in the chat, it looks like. There's one question about, do you have a preferred SSRI to start with in terms of side effect profile, as well as improvement in symptoms?
Yeah, so a lot of people will start with either, with one of the ones that have fewer side effects. For example, fluoxetine or Prozac can jazz people up. So people often won't pick that one. It also has somewhat more drug interactions. People will often pick the one that either Lexapro, pardon me if using the brand names, or Celexa, which is the one that was used in the study, as drugs that have lower rates of side effects. I've had to switch some people from Prozac when they couldn't tolerate it to another medication. One of my patients once said to me, taking Prozac was like looking at the world through rose-colored glasses. Being on, I think I switched her to Celexa. She said, it makes me feel better, but it's not quite the same. So that's one of the really interesting things, is the idiosyncratic element of people's responses to different medicines. And we used to think before the STAR-D study that you should switch to a different class. Let's say you start out with an SSRI, antidepressants, which are the most used. And we used to think you should switch to another category, like the SNRI, serotonin norepinephrine reuptake inhibitors. But the study in STAR-D showed us it really doesn't matter. You don't even need to change class. Just try something else. So, trial and error are really it's sad to say, but trial and error are the essence of what we use. People metabolize drugs very differently. And sometimes it is helpful to do the enzymes. And my friends who do mostly psychopharmacology do sometimes like to get profiles, because they're people who are very fast or slow metabolizers. Africans, where I did a lot of work in sub-Saharan Africa, are slow metabolizers of psychotropic drugs. So they use much lower doses in Africa. I once had a fight working on some WHO guidelines on their insistence on using evidence from European and US populations for Africa, when every psychiatrist practicing in Africa said we can't use those doses. So to some extent, African Americans also may be metabolizing drugs more slowly, yet it's highly variable. I did some work in Ethiopia, which is very interesting country, because there are people there who rapidly metabolize. The only drug that was available in SSRI there was fluoxetine. It was the first drug to become generic and therefore affordable. And there were some people who metabolized fluoxetine so rapidly that you could barely get a detectable level in the blood, and other people who were very slow metabolizers. And we couldn't really do studies in Africa because we didn't have the resources to look at drug metabolism. But it's just important to know that people have very idiosyncratic responses to therapeutic effects and to the side effects. They vary incredibly.
Great.
Everybody is an N of one.
There's another question about treatment of depression if you suspect bipolar disorder and are wary of using SSRIs in that context.
Yeah, so there's been a lot of discussion about antidepressants in bipolar disorder. The majority of the evidence is that by themselves, they're not helpful, and they can precipitate mania. So in general, we try to treat bipolar disorders with, we used to use mostly, lithium, which is still a great drug, but all of our medicines have side effects. And lithium requires blood monitoring, which of course we couldn't do in Africa, so we didn't use it there. So in Africa, people were more likely to use the anticonvulsants, which they happen to have on hand. And there are different ones that you can use. But more commonly now, I would say people are using the atypical antipsychotics just because they're easier to give. People overuse atypical antipsychotics, in my opinion, because they actually have a lot of metabolic side effects and other side effects that aren't so wonderful. And there are people who give them out as sleep medications. And I really, myself personally, would never give an antipsychotic to someone as a sleep medicine, unless I was truly desperate that I exhausted every other option, just because of their side effect profiles being so unfavorable. Anyway, the fact is that bipolar disorder needs different medications, and managing bipolar is much harder on a patient because people who have ups and downs are much less certain about how to stay well than people who are just dealing with a down mood. How about patients in denial? People are in denial. People are always in denial of having psychiatric illness. That's why, unfortunately, there's been a lot of evidence to show that if you can treat these disorders early, they are less incapacitating. That's true for all psychiatric illnesses, including the most severe ones like schizophrenia. But mostly young people don't accept having a mental illness. So a typical pattern is to see people continuously going off drugs and relapsing. And if you read biographies and autobiographies of which there are quite a few now out there, someone like Kay Jamison in Unquiet Mind, she's very famous for being a bipolar disorder, a very accomplished scientist who used to write about herself in textbooks. And then when it became more acceptable to be both a provider and a patient, then some people who were in both categories started to talk about it. So, and actually, I'll just add. I see I don't have much time left. So anyway, you know what? Denial is just part of having mental illness. It's what people have, and often it's not until it takes a long time to recognize that help people to recognize that the price they're paying for going untreated is too high.
Thank you. I think there was another question about discussion of HIV and active addiction. I think you touched on that a little bit in terms of depression and addiction.
Yeah, you know what? I once asked somebody who was Herb Cleaver, who ran our substance abuse division, may he rest in peace. I said, Herb, if there was only one thing that people could take away from people with substance use disorders and another psychiatric illness, I said, what would it be? And he said, 2 disorders, 2 treatments. So I always kept that in mind. And it doesn't mean you can't treat one while the other one is present. You could treat them both, but it's not a reason to reject people. For a long time, people with substance use disorders were rejected from things like depression treatment. You don't have to reject people. You can treat the depression, but the substance use disorder will mostly not get better and will need its own treatment. And so now that we've moved more toward harm reduction strategies, we can often work with treat what the patient is willing to have treated.
Thank you so much. I think those were most of the questions there. I want to thank you so much for your time again and for this excellent talk, everyone. And
if anyone has a question and wants to email me, my email, I think it's maybe on the first slide, but it's fc15@columbia.edu. And you're welcome to email me if there's something that you want to ask that you didn't want to ask in a public setting.
Thank you again, everyone. Have a wonderful day.
Thank you.